Thank you. So good evening, everyone. Tonight we're going to do a rapid review, hopefully, of dermatology and HIV. I chose this topic because I thought that us as HIV provider, it's very important to be familiar with the different cutaneous manifestations our patients can present with. Some may think it may not be as important as it was in the pre-ART era. However, we still encounter a very high prevalence of cutaneous manifestations. Almost 90% of our patients will have some cutaneous dermatological complaint at some time in their lifetime. Although the introduction of ART really significantly decreased the prevalence of some opportunistic infection-related skin diseases, decreased the prevalence of Kaposi sarcoma. However, it was noted that the prevalence of inflammatory-related skin diseases, primarily related to HIV, remains constant. There are some cutaneous findings that are very exclusive to HIV. However, the majority are the common dermatological manifestations that we encounter in our normal life. However, you should keep in mind that in an HIV host, these common dermatological manifestations will have more severe, more atypical, and more treatment-resistant pattern. Why is it important to really be familiar with these different cutaneous manifestations? First, because I'm hoping that we're going to review mainly the clinical manifestations of these different dermatological diseases, hoping to give you some idea how to make the diagnosis, to get to the right diagnosis of these different skin conditions. Because some of these skin conditions may be your first sign of an ongoing HIV infection. Because these various skin conditions can sometimes correlate with the level of immune suppression. So you are in a resource-limited settings, you're not sure what is the CD4 count of this patient, doing a good dermatological exam, looking inside his mouth, being able to diagnose some cutaneous lesions will give you an idea of the immune status of this patient. And third, to hopefully help you avoid the unnecessary discontinuation of some very successful ART, thinking that it's a drug allergy. So these different dermatological diseases start with the HIV patient from the beginning, 1 to 3 weeks after exposure, even before seroconversion. It's usually encountered in 50 to 70% of these patients as a part of the acute retroviral syndrome. It consists of a transient, non-pruritic, morbilliform eruption with bipolar apoptosis that usually involve mainly the upper part of the body and should disappear within 3 weeks. It was noted that it correlates with the higher level of viremia, and they think that this skin eruption is secondary to the wide dissemination of the virus. If you do some review of literature, you see that the resources usually divide the different clinical manifestations depending on whether they are inflammatory, infectious, neoplastic, or other. Today, in our discussion today, we're going to divide the different cutaneous manifestations depending on the CD4 count. First, we're going to start with the cutaneous manifestations that can be found at any CD4 count, but you should keep in mind that the lower the CD4, the more the atypical, severe, and the more the treatment-resistant cases you're going to encounter. So we're starting with the green part that these cutaneous diseases can be encountered at any CD4. First, with the Herpes Simplex virus. It's a rapid review. It can be caused by HSV1. HSV2 consists of an acute painful eruption of cluster group vesicles on an erythematous basis. What happened in an HIV host? In an HIV host, the most common herpetic presentation is anogenital ulcers. And it's mainly caused by HSV2, although we're hearing now there's an increased prevalence of HSV1 as a culprit for these anogenital ulcers, but they don't cause as much recurrence as HSV2. There was a lot of studies that really reviewed the interaction between HIV and HSV2, and they were able to find that HSV2 lead to an increased viral shedding of HIV, leading to increased HIV acquisition, increased HIV transmission, and increased HIV levels in plasma and genital secretions. Similar thing, HIV cause increased frequency of HSV2 shedding, increased HSV2 acquisition, and increased HSV2 transmission. Other than increased anogenital ulcers disease, what also can we see in an HIV? We see more atypical presentation. We see like linear erosions, we see shallow ulcers, and also, which is very characteristic of an advanced HIV stage, is a chronic herpetic ulcer. Whenever you see a herpetic ulcer that's been there for 1 month, this is highly suspicious of an ongoing HIV infection and an advanced disease. Next is the herpes zoster. Herpes zoster, we all know, a primary infection leads to chickenpox. A reactivation of a latent virus in a dorsal sensory ganglia will lead to the shingles, which is a painful unilateral dermatomal vesicular eruption usually occurring in somebody who's older than 50 years old. However, in an HIV patient, what we see is an increased risk for herpes zoster. We see herpes zoster occurring at an age less than 50. We see more atypical presentation. We see these hemorrhagic necrotic lesions, the monomorphic lesions, and also we see more severe scenarios. We see disseminated cases with a greater incidence of complications such as encephalitis, pneumonitis, and hepatitis. In picture 1, this is an example of a chickenpox. Picture 2 is an example of a disseminated zoster because it's involving more than one non-contagious dermatome. Picture 3 is an example also of a disseminated zoster because it's involving more than 2 contagious dermatome. And picture 4 of an atypical presentation with these hemorrhagic necrotic lesions. Next is the syphilis. Syphilis, which is a chronic systemic illness caused by the spirochete Treponema pallidum. Cutaneous manifestation in syphilis can be seen at different stages. Starting from the primary syphilis, we have the painless chancre that usually occurs 3 weeks after exposure, and usually is painless unless there is some bacterial superinfection. Then it becomes painful. Followed by secondary syphilis, which usually we have 3 cutaneous syndromes in here. You have first the famous psoriatiform papulosquamous rash with the palmar and plantar involvements. You have the condyloma lata, which are these white verrucous lesions, usually in the oral or genital area, and they are more flat than the condyloma acuminata that is caused by HPV. And there is also the Louis maligna, which also known as malignant syphilis or ulceronodular syphilis. This is a very rare manifestations of secondary syphilis, and it's usually only encountered in the HIV population. It consists of these nodulo-ulcerative lesions with a lot of systemic signs and vasculitis syndromes. And last but not least is the tertiary syphilis. Also there you can see some cutaneous manifestations related to this non-specific granulomatous lesions, the gammas that can develop in the skin, bone, mucous membrane, leading to skin ulcerations and palatal perforations. Here are some pictures. So in picture A and B, you have the palmar syphilititis psoriasiform rash. In C, you have the Louis maligna. And the last picture, you have the palatal perforation and the skin erosion secondary to these gammas. So it's very important to look inside the mouth. In HIV patients, what else than the Louis maligna? What also you may encounter? The chancre usually lasts longer. So what happens, you will see a concurrent primary and secondary syphilis. It's much more common in HIV. And also the latent period is shorter. So you will have a rapid progression to tertiary disease, and you will have early tertiary disease, mainly meningovascular syphilis. And the third, you have more propensity for relapse. Moving on to the Tinea, the dermatophytosis, the famous ringworms. These superficial fungal infections that can affect the hair, skin, and nails. The 3 most common dermatophytes affecting the humans are the trichophyton, the microsporum, and epidermophyton. The most common one is the trichophyton rubrum. In HIV, we witness a lot of dramatic and generalized cases of Tineas, and they are usually treatment resistant. The tinea, as you can see in picture 8, it consists of a well-demarcated annular erythematous patch with central clearing and a fine scale. In picture B, you can see the tinea capitis, this patch of alopecia with these black dots which are characteristic of the broken hair shafts. And in C, you see the proximal superficial white onychomycosis, which is very characteristic of an HIV infection. Continuing with the papulosquamous rashes, so we have the psoriasis. A rapid review of psoriasis, it's an autoimmune disease affecting 3% of the population according to the National Psoriasis Foundation. These psoriatic flares usually are triggered by stress, friction, UV lights, drugs, and infections, consist of well-defined erythematous plaques with silvery scales, and also a quick reminder about the Koebner phenomenon seen in psoriasis, where an abrasion can lead to psoriatic lesions. In HIV, it's not like you have a higher prevalence of psoriasis. It's just that HIV, with its immune alterations, can unreveal a psoriasis case. And the lower your CD4, the more psoriasis flare-ups you're going to have. So just by restoring your immune system and starting him on antiretroviral therapy, you'll help the patient improving her skin disease. The only thing they don't notice an increased incidence of psoriatic arthritis in HIV patients. Similar is the seborrheic dermatitis, which is a chronic relapsing inflammatory skin condition with a predilection for areas rich in sebaceous glands. It's mainly caused by a normal skin inhabitant, which is the Malassezia furfur. It's a lipophilic yeast and lead to this widespread inflammatory and hyperkeratotic patches, the erythroderma. These seborrheic dermatitis can be itchy sometimes. HIV patients have a lot of, you see a lot of seborrheic dermatitis in the HIV population. Almost half of our HIV patients will have seborrheic dermatitis. In the HIV patients also, it will be more severe, more extensive, and treatment resistant. Sometimes it could be your initial cutaneous manifestations of HIV disease. And since it's very rare, barely seen in African American patients, whenever you see an African American that have a seborrheic dermatitis, this is highly suggestive of an HIV infection. Moving on to the bacterial infections. In HIV patients, the most common bacterial pathogens is Staph aureus, with an increasing now with the MRSA, increasing concern with the MRSA. They usually get a lot of folliculitis, furuncles, carbuncles, and they are more predisposed to have more disseminated, deep-seated infections and sepsis because of that. So here are some pictures of some staph infections, starting with impetigo, ecthyma, Psychosis barba, which is folliculitis at the beard side, furuncles, carbuncles, and cellulitis. Let's go to a case now. So we have a 30-year-old male who was recently diagnosed with HIV during a routine ER visit for minor trauma. His CD4 count was 400, viral load 50,000. He was started on efavirenz, tenofovir, and emtricitabine. His most recent sexual contact was 90 days ago with an anonymous partner. He was RPR negative at that time, and again when he started the ART. 11 days after starting therapy, he developed an itchy rash over his trunk, face, and extremities, including palms and soles. He has no blistering lesions, no lesions on his oral mucosa. All right. So what is your next step? Will you continue the same ART regimen? Will you switch the efavirenz to lopinavir? Do you start him on topical steroid, or will you treat him with benzathine penicillin? Any suggestions? Penicillin? You think it's a secondary syphilis? Secondary syphilis is usually non-paralytic. And his RPR was negative. Okay, we will continue with the same ART regimens. NNRTI and mainly efavirenz are very well known to cause these urticaria rashes, usually starting within 2 weeks after starting the medication, and usually they are transient, so within 4 weeks they should go away. You always have to look for any alarming signs, and these are any blistering lesions, mucosal involvements, or some blistering or mucosal involvements or target lesions even. If, in case you see one of those, you should discontinue the medications because you don't want him to progress to something more severe. Otherwise, you continue the ART and the rash should go away. Just keep an eye on him. This is an example of the rash. HIV patients are known to have higher frequency of hypersensitivity and drug allergies. It was noted that an HIV patient, 20 to 80% get hypersensitivity to trimethoprim sulfa compared with only 1 to 3% in the general populations. What is the mechanism behind that? Nobody really understood that, but it could be maybe because of altered drug metabolism, decreased glutathione levels, or both. And you can go to New England Journal of Medicine 2006, there was an article about that. Some drug reactions that you should be aware of are first erythema multiforme, which is characteristic target lesions, the iris lesions. When you see an erythema multiforme, you should stop the medication and don't re-challenge the patient, because this patient will progress into Stevens-Johnson's toxic epidermal necrolysis. The main culprit of the erythema multiforme are NNRTI, raltegravir, abacavir, and sulfa. As for the abacavir famous drug hypersensitivity reaction, it only occurs in 8% of the abacavir patients. Taking abacavir usually occurs after 9 days, but can occur up to 42 days later. The rash in the drug hypersensitivity reaction is very discrete. They mainly have more systemic and metabolic derangements. But now we don't see it anymore since we do this HLA-B5701 screening, so it's from the past. And also we have the fixed drug eruption, which caused mainly by darunavir and some antibiotics like the sulfa. And now what we fear the most is the Stevens-Johnson syndrome and toxic epidermal necrolysis. It was noted that there's a higher incidence in HIV and higher mortality also in HIV patients. Usually they start with a prodromal illness, flu-like illness, and then you see a very highly disseminated extensive erythema multiforme on the trunk with blistering, with erosion and mucosal involvement. Stevens-Johnson is when you have lesions involving less than 10% of the body surface area. Toxic epidermal necrolysis when you have more than 30% of the body surface area is involved. Stevens-Johnson, usually only 50% of the cases are secondary to drugs. As for toxic epidermal necrolysis, like almost 95% of the cases are secondary to drugs. So these are some examples of the drugs can lead to toxic epidermal necrolysis. From the ART standpoint, we have a lot in the NNRTIs, efavirenz, nevirapine, and zidovudine. Antimicrobial, you have sulfonamide, fluconazole, vanco, penicillin, and some anticonvulsant and NSAIDs medications, along with the list is pretty long. So we finished with the cutaneous manifestations that you can see at any CD4. Moving on to the cutaneous manifestations that you start seeing when your CD4 drops below 500. First is the tinea or pityriasis versicolor, which is also caused by Malassezia furfur. At this time, you start seeing more recurrent cases and more persistent cases. This is an asymptomatic hypopigmented macules that do not tan, usually noticed during the summer and mainly in the upper part of the body. As for the Malassezia folliculitis, these are these papular pustular lesions over the face, scalp, trunk, and proximal arms. Also caused, of course, by Malassezia furfur. Next is the human papillomavirus. As we all know, there's over more than 100 types of human papillomavirus in the world that can cause anything, starting from the common warts, verruca vulgaris, plantar warts, condyloma acuminata, and anogenital dysplasia and anogenital cancers by downregulating, I think, a tumor suppressor gene. In the HIV, it was noted that there's a higher prevalence of genital warts. Almost 17% of the patient will have a genital wart. What's the mechanism behind that? First, if you know, after you get an HPV infection, there's like a subclinical latent period of like 1 to 8 months before any clinical or histopathological changes. And then, so the key behind any pathogenicity of the HPV is it's persistent inside these epithelial cells, which is facilitated if you have a decreased cellular immune response. And so until today, we don't have any modality of treatment or anything to really target the virus. We're just dealing with the consequences, either removing the warts or either treating the cancers. What we can do is increase in the cell-mediated immunity through starting antiretroviral therapy that will help regress, control the reactivation, prevent recurrence, and elimination of warts. And of course, we have the vaccination. Other characteristic stuffs you can see in an HIV population related to the HPV infections are the atypical presentations. You see these giant tumors, these giant condylomas called Buschke-Lowenstein tumors. They are very characteristic of HIV. Also the unusual locations. You see these condylomas on the arms, on the lips, and they are usually recalcitrant to therapy. Now we have the vaccinations. We have the bivalent and the quadrivalent. The quadrivalent, the Gardasil, was approved to be used in HIV men and women through age 26. It contains the two 6 and 11 non-oncogenic strains that cause 90% of the genital warts, and 16 and 18, which are the oncogenic strains that leads to 70% of cervical cancer, 80% of anal cancers, 60% of vaginal cancers, and 40% of vulvar cancers. So you can offer it through age 26 to our HIV patients. Moving on to the famous scabies, the human itch mite caused by sarcopte scabies. It consists of an eruption of a pruritic papules and burrows, but really don't count on looking for the burrows because you will miss a lot of cases of scabies. It usually favors the wrist, the interdigital web space, the elbows, the axilla, the breast, and genitalis. The genitalis is very characteristic of scabies. They say if you find an itchy bump in the genital area, consider it as a scabies until proven otherwise. It's usually transmitted by prolonged skin-to-skin contact with the infected person. So persons who have a contact of this nature and not those with more casual contact should be treated. The Norwegian Scabies, which we usually see when your CD4 drops below 150, it's also known as the crusted scabies or hyperkeratotic scabies. It's a very dramatic and severe form of scabies. Consists of the thick scaling white-gray plaques with fissuring, and they're usually non-pruritic. It's localized usually to the scalp, face, back, buttocks, and feet. And these fissures are very problematic because they provide an entry for bacteria leading to increased risk of sepsis in these patients. These Norwegian scabies is very hard to treat and it's very contagious. And why is that? Because it contains an incredibly large number of mites. Like in every gram, you have 10,000 mites. So it's very easily transmissible. And so anyone who was in contact with this patient, whether he's symptomatic or not, who should get treated. And now moving to a rare disease, but it's a very important disease, which are the cutaneous lymphomas. Cutaneous lymphomas can be caused by B cells or T cells. If it's a cutaneous B cell lymphoma, it usually looks like a Kaposi sarcoma, and it looks like a violaceous red nodules. As for the T cell lymphoma, the most common form is the mycosis fungoid. And the mycosis fungoid lesions really differ depending on the stage. In stage 1, you will have a simple eczematous patch, and it will turn out that it's an early stage of a cutaneous T cell lymphoma. Stage 2 is a plaque stage, and stage 3 is an actual mass sitting on the skin that can get ulcerated and infected. As for the Sézary syndrome, I don't know if it's an advanced stage of mycosis fungoid or it's a different entity, but it consists of erythroderma of all your body. It's a very painful and itchy disease, and that usually involves also the palms and soles. And here are some pictures. So we have the stage 1 of mycosis fungoid, which consists of an eczematous patch. Stage 2, it's a plaque stage. Stage 3, it consists of actual masses on your skin, and the Sézary syndrome. So we're done from this, done from that. Moving on to when your CD4 drops below 200. And what are the skin manifestations that you start seeing? First, the famous Candida. We know that Candida is a normal inhabitant of our oral and GI tract. Oral candidiasis is the most common fungal disease of HIV-positive patient. And in the US, recurrent vaginal candidiasis was found to be the most common presentation of HIV infection in women. Whenever you see an oral thrush in a patient who doesn't have any risk factor for that, like he's not on inhaled steroids, he's not diabetic, this should raise your suspicion for an HIV infection. And since Candidal esophagitis is the most common cause of adenophagia and dysphagia in HIV-infected patient, whenever a patient complains of that, we start him on an antifungal therapy. And if there's no improvement in 72 hours, you go ahead and scope him. As for the Epstein-Barr virus, the famous oral hairy leukoplegia, it's very characteristic of HIV. And it consists of a very benign hyperplasia of the oral mucosa leading to this ribbed whiteness in the lateral aspect of the tongue that do not scrape off. It is not premalignant, and what you should do is start him on ART and it will go away. Continuing with the viruses, we have the Molluscum Contagiosum. It's a DNA pox virus can cause these benign skin lesions. Usually, it's on the face and the genital areas related to direct skin-to-skin contacts and also sexual contact. They usually goes away within weeks or months. But in an HIV patient, the lesions can be much more numerous, much more verrucous, larger, and an ulcerate. And what is very characteristic of an advanced stage of HIV, when you see these large, giant molluscums in the face, it's very characteristic of late HIV disease with a CD4 less than 100. And to be noted that the spontaneous healing in an HIV patient is rare, not like a normal person. Next is when your CD4 count drops below 200. This is when you start seeing the deep fungal infection with their cutaneous manifestations that should raise your suspicion of an ongoing systemic infection. Starting with the histoplasmosis. Histoplasmosis can cause direct skin disease by directly affecting the skin and causing these papulopustular nodular lesions that if you do a biopsy of those, you will see the fungus inside. But it can also lead to indirect skin lesions. And these are related to the immune reaction to a primary infection in the lungs, leading to erythema nodosum and erythema multiforme. Same thing for blastomycosis. Although blastomycosis cutaneous manifestations are the most common extrapulmonary manifestations of this dimorphic fungi. And it can cause direct lesions consisting of these verrucous nodular lesions or indirect lesions, and they are the erythema nodosum. Also, coccidio can cause direct lesion, hemorrhagic papules or nodules, or indirect erythema multiforme and erythema nodosum. These explosive lesions with this very characteristic colorette of scales are the Bacillary Angiomatosis lesions that are mainly caused by Bartonella hansla. These are multiple angioproliferative lesions on skin, mucosa, and internal organs. And when it's in the liver, it's called Pileosis hepatis. They resemble a cherry angioma. And what looks like that also are the Kaposi sarcomas. These are vascular neoplastic conditions linked to the infection with HHV8. There are 4 different types of Kaposi sarcoma. There's the classic types that usually seen in middle-aged men in the Mediterranean and Jewish descent. There's the endemic type that was usually seen in the pre-ART era in sub-Saharan Africa. There's the epidemic type, which is seen in the is AIDS associated, and it's usually the most aggressive type. And there's now the iatrogenic type that we see with the patient solid organ transplant, the receiving immunosuppressions. This is a picture of a Kaposi sarcoma, how it starts as a red or brown violaceous macules that can develop into plaques and nodules that can ulcerate and can disseminate into all your mucosa. Moving to a simple but very common cutaneous manifestation in HIV, which is the dry skin, also known as xerosis. It's seen in 20% of patients with HIV, and it's a main cause of pruritus in AIDS patients as well as in most immunocompromised patients. It's simple, rough, dry, itchy skin. As for the acquired ichthyosis, it's something different. Ichthyosis is derived from the ancient Greek root and means ichthys, means fish. And as you can see, it's like a fish skin. The scales are small, fine, irregular, and polygonal in shape, and give the skin a rough feel. Acquired ichthyosis usually begin on the lower extremities, and if you have an advanced HIV, they will progress. They will disseminate more, but they usually spare the face because of increased sebaceous secretions, so they don't get the face. They are limited to the lower part. I'm going to continue with the inflammatory skin diseases, and this is very characteristic of HIV infection. These are the pruritic papillary eruptions. They are very common in HIV patients, and they are very characteristics of HIV patients. They are encountered in 45% of these HIV patients, and they are a diagnosis of exclusion of any psoriatic pruritic rash. We have 2 subcategories. We have the Eosinophilic Folliculitis, which usually encountered when your CD4 is above 50, and it can be part also of immune reconstitution syndrome. And you have your Prurigo Simplex, which usually encountered when your CD4 is less than 50. So this is the eosinophilic folliculitis. This is how it looks like. It's a very pruritic skin condition consisting of these subcentimetric erythematous, perifollicular, papules, and pustular lesions. And the distribution is very characteristic. It usually includes the forehead, the neck, the shoulders, the trunk, and the upper arms. And because the patient is very consumed with itching, sometimes all you may encounter is the secondary changes, which are either the inflammatory hyperpigmentations, the lichen simplex chronicus, the bacterial superinfections. As when your CD4 goes below 50, this is when you see the Prurigo Nodularis. And these are consisting of a small pruritic, purpuric, or skin-colored nodules, usually on the arms or legs with secondary excoriations. And also in here, you may only be seeing the result of the chronic and repetitive scratching. Etiology was unknown until a Ugandan study was done, and where they did a biopsy of these lesions, and they found that there's an arthropod insult. And that's why Prurigo Nodularis now is also known as hypersensitivity, insect bite hypersensitivity. Okay. Another Molluscum Contagiosum-like lesion is the cryptococcosis. And usually when the CD4 is less than 50, and if you see a Molluscum Contagiosum-like lesion, you should suspect a case of a disseminated cryptococcosis. Also Penicillium marneffii infection, but it's usually an endemic dimorphic fungi in the Southeast Asia, also can cause a Molluscum Contagiosum-like lesions in a patient with CD4 less than 50. So what if you start the antiretroviral therapy? There's another subcategory of skin manifestations that you may encounter 1 to 3 months after starting the new antiretroviral therapy. And these are the immune reconstitution acne, the immune reconstitution acne rosacea, the eosinophilic dermatitis, and also some infectious like HSV, VZV, and Kaposi sarcoma and genital warts. So immune reconstitution acne is similar to any acne vulgaris. It's just an area of seborrheas, comedones, papules, nodules, and scarring. The immune reconstitution acne and rosacea consists of, as we all know, of redness, mainly in the central face, of telangiectasia, of red gritty eyes, and the rhinophyma. Are you aware that persons age 55 and older account for 90% of the estimated 1.1 million people living with HIV infection in the United States in 2010? Research indicates that by 2015, half of the HIV patients in the US will be over more than 50 years old. So in recognition of the National HIV/AIDS and Aging Awareness Day, which is on September 18th, I'm going to do a rapid review of some dermatological disease that you may encounter in successfully treated aging HIV populations, which are actinic keratosis, skin cancers, and herpes vegetans. Actinic keratosis, also known as solar keratosis or senile keratosis, is a pre-malignant condition consisting of a thick, scaly, or crusty patch very adherent to the skin. Usually you feel it more than you can see it. And it's usually on the sun-exposed area secondary to solar damage. Untreated lesions have a 20% risk of developing into squamous cell carcinoma. That's why you should keep an eye on these lesions. If you see any change, like they start bleeding or anything, you should get a biopsy to make sure they didn't progress. Skin cancers. Risk factors are usually fair-skinned, increasing age, and longer duration of HIV infection. So we have an increased prevalence of basal cell carcinoma and squamous cell carcinoma in the HIV population. They are usually more aggressive in these patients and with more recurrence. And last is the herpes vegetans. Herpes vegetan is a herpetic verrucous lesion usually encountered in the anal area. And it's very painful, and most of the time it's confused with a squamous cell carcinoma. It's usually caused by acyclovir-resistant herpes simplex, and it's seen in these old patients that have been exposed to irregular use of acyclovir in the past. Another hint is that whenever you see multiple skin lesions, like you have a thrush and you have a psoriasis, always think that this patient may have an HIV. And this is a summary of what are pruritics and what are the lesions that are non-pruritic. I think I put it in the handout. Yeah. Thank you.